Welcome to our National CME series hosted by the Center for Vein Restoration. We thank you for your attendance this afternoon. At this time, I would like to introduce our President and CEO, Dr. Sanjeev Lakhanpal, who will provide further information about our National CME series.
Thanks, Jessica. Guys, welcome once again to our national series. We present this with a lot of pride and gratitude to all of the CVR physicians who stay committed to education. And this CME series is more like a platform where we, on one hand, have physicians in the forefront, our primary care doctors, our internists, and every other physician who looks to provide complete care. And on the other hand, we are joining together physicians who are experts in vein care here in the United States and around the world. So with that, I would take you to the topic for the day. Our topic today is lymphedema. As we're all committed to complete patient care, we've realized over the years that lymphedema falls in that category of almost being a stepchild. And it's too often that people are told that they have lymphedema when they actually do not, and they have more treatable forms of edema. And once in a while, they have lymphedema, which is not being treated right. So we really want everybody to have a conversation about lymphedema so that we can take better care of these patients. And for that conversation today, we have our own expert, Dr. Vinay Satwah. Vinay is a board-certified cardiologist, board-certified interventional cardiologist who has really dedicated his life and his expertise to treatment of peripheral vascular disorders. He has special interest in patients suffering from lymphedema as well. Vinay is one of our superstars that sees probably more patients within CVR than any other physician. So with that, Vinay, please, if you could start the conversation.
Thank you, Dr. Lakhanpal, for that very, very kind introduction. Far too kind. I really appreciate that. And I also want to echo your sentiment and appreciation to everybody who is on the call today on this webinar. Congratulations to Center for Vein Restoration for this National Summer Series. And I'm truly proud to be a part of this initiative. And so as Dr. Lakhanpal has mentioned, lymphedema certainly is or can be the stepchild in vascular diseases. And the way we typically look at when we think about circulation disorders, first thing that comes to mind is either the arterial or the venous system. And oftentimes what happens is the lymphatic system gets forgotten. And we are treating patients, we're trying our best to help these patients that are coming through our clinics. But sometimes if we're not thinking of the complete diagnosis of circulatory disorders and including the lymphatic system in that, then our patients may ultimately not get the best care that they deserve. And so when patients present to our clinic, again, it's all about trying to come up with a system, of evaluating your patients, a reproducible system. So then at the end of the day, the patient gets the care they need, you are feeling comfortable that you didn't forget or leave potentially anything out. And so where do I begin? That's where I typically start, with a patient that comes in with a vascular evaluation and symptoms primarily of swelling. Well, common things being common, we have to rule out systemic causes first, right? Could it be potentially, related to the heart, the kidneys, the liver? And so most of our patients, most of our wonderful primary care doctors in the community and the medical subspecialties do a fantastic job of evaluating those patients for systemic causes. And so once those patients have had that ruled out, then the next question is, if the answer is no to systemic causes, then how acute or chronic is the swelling? How long has the swelling been there? And that's important because all of us know that if a patient comes through with chronic swelling, on our radar, the first thing we're going to be concerned about is acute deep vein thrombosis. So we'll do a great job of ruling these patients out and making sure that that's not the cause. Well, I'll tell you, one of the other common things we've noticed in our practices is that we ask the patient, how long have you been on your medications? And invariably, many of these patients may have started a medication that has a side effect of swelling. And it's a very simple answer. You change the medication, you adjust the dosing, and these patients get better. Well, again, that's all easy, right? But we know that a majority of the patients that we are evaluating in our practices have chronic swelling, right? And the talk really is going to focus on patients that come in with chronic swelling, defined as more than 72 hours, and where we can classify these patients. Is it a venous problem? Is it a lymphatic problem? Or is it a combined problem? And so before we get started, I think like anything, we need to understand the big picture, right? I'm not a physiologist by any means, but I think that if we're going to treat something, we need to understand what we're treating. And we need to understand why is it happening, right? So we have to appreciate the fact that our body is a recycling center, okay? 20 liters of fluid go through our body throughout a day that need to be recycled. And so our venous system and our lymphatic channels are really working hard to make sure that this fluid is being retained and being recycled. And so the first question is, why is it important? Well, it's very important, ladies and gentlemen, because again, 20 liters of fluid in our body is being recycled to these systems respectively. Now, I mentioned venous, lymphatic, or a combination of the two. Well, if there's not anything else you take from this talk, I do want everybody, please understand, if you don't already, that there's a very, very intimate connection between the venous system and the lymphatic system. So what do I mean by that? Well, take for instance this illustration. So we know that the veins job, again, we're not, this is, please, by no means am I trying to, be too elemental here, but we understand that veins take blood back up to the heart, right? They work against gravity, the pressure backs up in the veins, and as the pressure backs up, you're going to notice that the pressure within the vessel itself is going to cause fluid to go from a high pressure system to a low pressure system. So as the venous system starts to become insufficient, the fluid starts to collect, the blood starts to collect in the vein, then that fluid is going to start making its way out of the vein into the interstitial space. So now what happens? Well, the interstitial space is where that fluid continues to collect. The lymphatic system's job is to take over and help return that fluid that is collecting in the interstitium due to the incompetence of the venous side. So in other words, the lymphatic channels are correcting or helping negate some of that fluid that is collecting due to the insufficient venous system. But over time, what will happen is, if you imagine the interstitium gets overloaded, that fluid is making its way into the lymphatic channels. The lymphatic channels are doing their best to get that fluid back up. Not only are they taking over the job of the venous system, but they're also trying to hold on to the baseline recirculation that they were doing, or recycling they were doing throughout the day. And over time, as you can imagine, the system starts to become overtaxed. And that then leads to lymphatic insufficiency. If we have venous insufficiency, we can then have lymphatic insufficiency. And then unfortunately, over time, as the lymphatic systems start to become overburdened and taxed, I will show you some slides where many of our patients will come through and have, unfortunately, the clinical ramifications of that. Before we get started onto the clinical side, I want to just explain to you the concept, or how this concept has been overlooked for so many years. Ladies and gentlemen, it is not our fault. We went to school, we learned about the Starling Principle, we all memorized it for the exam, and many of us may have not remembered it after the exam, like me, but it's a very simple concept. The Starling Principle says that fluid goes from a high pressure system to a low pressure system. And we all understand that, and it all makes sense. But what the Starling Principle originally was trying to say was that as the fluid was in the high pressure system into the low pressure system, over time, that imbalance then caused the fluid to go back into the venous system, where that pressure would theoretically be lower. And so at the end of the day, the net fluid movement out would be the same fluid movement back into the vessel. And again, inherently, it would make sense. But there's research that has been done that has now updated the Starling Principle. And the revised Starling Principle now states, yes, fluid does go from a high pressure system to a low pressure system. Totally makes sense. But where we were hypothesizing or thinking that that fluid then eventually would go back into the low pressure system, that being the venous circulation, well, a lot of that fluid may not necessarily be going back into the venous, into the vessels of the venous system. And that fluid actually is being picked up into the lymphatics. Now, the veins have a glycocalyx model, a glycocalyx layer. Well, what the heck does that mean? Well, the veins have a very, very tight wall of smooth muscle cells. And so that wall is not as permeable as we used to think it was. So that lack of permeability then leaves more fluid in the interstitium. And thereby, the point here is that the lymphatics have been under-recognized and underappreciated for many years physiologically. And now that the Starling Principle has been revised, it's important that we continue to understand it and apply it in our respective practices. Why is lymphatic fluid so important? 96% of it is water. Water is important, right? And the 4% of it is equally important because you think about it, you have the lipids, you have carbohydrates, you have proteins that are very, very important to our bodies. And then finally, lymphatic circulation, right? If our lymphocytes are not being adequately recirculated, then what will happen is we'll be prone to infection, right? Totally makes sense. So why am I so passionate about this? As Dr. Lokenpaul very nicely said, I've been evaluating a lot of patients like my colleagues at Center for Vein Restoration, and we've really started to appreciate this more and more. Ladies and gentlemen, millions of people are walking around with under-recognized, underappreciated lymphedema, and they're in all our practices. But we have to understand and recognize that phlebolymphedema, venous intermutual dependence with the lymphatic system, is the #1 cause of lower extremity swelling in Western countries. Why? As I explained to you, as the venous system becomes incompetent, the lymphatic system then becomes overtaxed. And over time, if we do not recognize that and we don't adequately treat it, that's going to continue to become a burden on the lymphatic side. So that then will lead to other problems down the road clinically. Lymphedema can be both primary and or secondary. It's important to ask your patients that have chronic swelling, when did this occur? Has this occurred during your childhood, your teenage years? And many of them may relate and open up to you and say, you know what, I've always been told that I had big legs. And I remember being ridiculed in school. I remember not being able to wear shorts or what have you. And so they'll open up and start telling you about this. Well, it's important to understand that if that is a diagnosis, because primary lymphedema needs to be addressed, because these patients will go throughout life and then develop the ramifications clinically of the lymphedema. Again, secondary lymphedema, the most common cause is chronic venous insufficiency. We have patients that are already under-recognized in practices throughout the country that have venous disease, right? We already know that we already have one strike against us with that. But now on top of that, the patients that have venous disease that are under-recognized, the lymphatic component needs more attention. The other thing I want to highlight is, I don't know if there's anybody in this country that doesn't have a patient that is obese. If that's the fact, then I would like to know where you practice, because obesity has become more and more rampant. Obesity will lead to pelvic venous incompetence. As the pressure in the midsection increases, the pelvic veins are under more pressure, and that then pressure translates down into the legs. How many of our patients have had some sort of surgery in the pelvic area? It's always important to ask those questions. Have you had any surgeries in the pelvic area? Because scar tissue can develop invariably, just like with trauma. Same thing in the knees. Have you had knee surgery? Have you had any type of replacement of any sort? Have you had any type of trauma? Trauma and surgery will invariably lead to scar tissue that then contributes to the formation of resistance to the lymphatic channels, thereby leading to lymphedema. Lymphedema is not an overnight process. We understand that. Lymphedema is chronic. And we must understand that many patients are in a latent phase of lymphedema. They may come and say, Doc, I don't understand. I was doing great. And all of a sudden, over the past couple of months, my foot looks like this. What did I do wrong? Did I eat something wrong? Did I do something wrong? Tell me, please, how do I fix this problem? Well, again, many of them, they have to understand that this is not something that just started. This has been in a latent phase for many years and slowly has progressed. And sometimes something can tip them over the edge, just like venous insufficiency. And so it's important to have a conversation with the patient so that they understand that the process of helping them, there's no cure for this, there are only treatments, and they have to stick to the treatments and remain compliant. Now, I like to connect the venous and lymphatic system with these slides because for some people that are doubting the phlebial lymphedema concept, I hope that this would help you understand it more and appreciate it more. This is a radionuclide lymphoscintigram that you see at the bottom here. And just as a healthy review, patients have the radionuclide injected into the lymphatic system. Lymphoscintigraphy, then they have scans taken, and basically the radioactive nucleotide medicine goes up and mimics the flow of the lymphatic channels. And as you can see in panel A here, this is a normal, healthy lymphatic channel. Over time, as we're following it, the medicine is making its way up, which we would want. You want that lymphatic fluid to make its way up north. But if you look in panel B here, most of it is collecting in the medial ankle segment in the left and right side. This is dermal backflow. Dermal backflow is the incompetence of the lymphatics. And in this scenario, this is a patient that has it in both medial ankles. Well, now make your way to panel to the right here. This is a patient that came to the clinic who had active ulceration. Lymphoscintigraphy was done on this patient, and not surprisingly, you see lymphatic incompetence in the left leg. You see the pooling of that radionucleotide. But look at the right leg, ladies and gentlemen. This patient has C0 disease. There's nothing visible in the patient's right leg. Yet there's already venous incompetence occurring, and lymphatic incompetence occurring here. So what is my point? My point is that latent phase lymphedema exists. Many of the patients are in the latent phase. They don't know they have it. And it's upon us to make sure that we keep the diagnosis in our differential, and we don't forget and lose sight of the fact that these patients are at increased risk of developing lymphedema down the road. But we know many of our patients, unfortunately, wait. And by the time they actually seek help, they are at the C3 phase. And C3 basically means that the patient has edema, okay? Doc, why is my edema there? Why is my leg swollen? Is it, again, something I'm eating? Do I need to lose weight? Well, the answer probably is a combination of that. But what I want to make sure we understand here is that C3 disease, whether it's pitting or non-pitting, you can translate that into the lymphedema side with stage 1 and stage 2. What is the main difference between the stage 1 and stage 2 of lymphedema? Well, mostly, again, it's the progression of the lymphatic regurgitation occurring. So as the lymphatic fluid starts to back up, the swelling is going to occur, initially being pitting. And the patient's going to say, when I elevate my leg, just like on the venous side, when I elevate my leg or when I wear compression, the swelling gets better. Okay, this is a sign physiologically that the lymphatic system is starting to become overburdened. But as the patient then makes their way into stage 2, that swelling starts to become more spongy, starts becoming more fibrotic, because now you have the protein that's starting to settle, causing the skin to become thick. Hyperkeratosis will occur. And these patients will say, now when I elevate my legs, the swelling does not get better. And that's what's differentiating stage 1 from stage 2, because now the lymphatics are starting to become obstructed, and this disease process is making its way into the next level. Our C4 patients now have that chronic pigmentation, which we're very familiar with. We understand they have that brawny, leathery appearance. But again, that again goes hand in hand with the lymphatic regurgitation. As fibrosis is occurring, protein buildup is occurring, lymphatic impairment continues to worsen. And then our third stage here of active ulceration at C6. What I want to make sure we all understand is that we may do a great job of healing these ulcers, whether it be with wound care, whether it be with venous treatments, which are very important. But I want to make sure we understand that when the ulcer heals, the lymphatic system may still be compromised. Why? Because again, as I mentioned, there is scarring of the tissue that occurs, and that is scarring that we may not necessarily see. that scarring is within the dermal layers. That can then lead to lymphatic regurgitation. So my point here is that we want to make sure that we're treating as well as we can from a lymphatic standpoint. But many of my colleagues will say, how do you see so many patients with lymphedema? What are you doing differently? We're not doing anything differently. What we're understanding, though, is that this is not just the patient that has lymphedema. And I think one of the biggest misunderstandings in our community is that if a patient doesn't have elephantiasis, they don't have lymphedema. And I want to say it again. Lymphedema does not only equal elephantiasis. And I think, again, a lot of our colleagues may think so, but we don't obviously want our patients ever to get to this point because it's very sad. But these patients, we've seen them, they do well. It takes a long time. It's a long process. But again, our job is to catch this sooner than later and really try to prevent the patient from getting to this stage. So what are some symptoms in the clinic that we're looking for? And what are some clinical diagnostic tests we can use? Well, many of us have heard of Stemmer's sign. Stemmer's sign is a positive predictive test. Basically what it is pinching the second digit of the base of the toe and seeing if it compresses. If it does not compress, in other words, if the skin is taut, that's a positive Stemmer's sign. So that means the predictive value of the Stemmer's sign is very high in that if it doesn't compress and your skin stays taut, likelihood of the patient having lymphedema is very high. The other thing you may see is patients having squared and swollen toes, often looking like sausage links. Many of them, they can't wear closed shoes. They have to wear open toe shoes or sandals, or they're walking around and they say that I just can't fit in my shoes. Many times they say I have to wear a size larger or two to really be able to get around. Many of these patients, you'll see classic swelling in the dorsum or the top of their feet. And again, sometimes when they're wearing their shoes, you can actually see the dorsum, the hump sticking out of the shoe. Again, as the lymphatics worsen, keratosis occurs, fibrosis occurs, you may have leakage of the lymphatic fluid through the skin called lymphorrhea, which is, again, really sad. A lot of these patients will say, Doc, I wear these ACE wraps and they just seep and leak, and it's all that lymphatic fluid that's sitting in there. And again, for my podiatry colleagues who are on the call today, this is a team-oriented approach. We need you. We need each other. And so I work very closely with our podiatry colleagues to help these patients because, again, they need proper foot care. And again, it's a really important team-oriented approach. Up until this point, I've spoken about superficial venous insufficiency. But for those of us who understand and recognize, we all should, but understand and recognize that the venous system can also have a negative impact if there's insufficiency in the deep system up higher in the pelvic area. What about those patients? And so I don't think any deep venous lecture should ever be given, and I'm biased because he's my mentor, but Dr. Raju has done a lot of research in the deep venous space. And I wanted to highlight this study that he published in the Journal of Vascular Surgery in 2012, where he looked at patients who had deep venous disease, patients who had a narrowing in their pelvic veins that was leading to a decrease in flow. So their superficial system was treated or may have some slight incompetence, but the deep pelvic system was the problem where the insult was mostly. So what about these patients? So he looked at over 440 patients who had a diagnosis of venous insufficiency, but then on top of that also had compression of their pelvic vein or narrowing in their pelvic veins, thereby leading to the chronic swelling. And what he did was he diagnosed it with venography, where he injected dye, and intravascular ultrasound, where he put a catheter to get a three-dimensional view. So these patients were properly identified. And then what he did was lymphoscintigraphy to then identify the lymphedema in these patients. And he found 205 without it and 72 with it. So now to follow, we have patients who have a diagnosis of pelvic venous narrowing of some sort, okay, with lymphedema versus not having lymphedema. And over 40 months, he followed both groups. They were treated with venous stenting. And at 40 months, what he found was the patients that did not have lymphedema and only venous outflow narrowing did much better than the patients that had both venous outflow narrowing and lymphatic insults. And furthermore, what he found was that at 40 months, when he did lymphoscintigraphy again on those patients that got stented, the patients that had the abnormal lymphoscintigraphy initially, 25% of them had not only improvement, and some of them even normalized. So the whole point of this article was that we cannot forget that deep venous disease is important. Deep venous disease is equally important when we're evaluating patients with circulation disorders. And so if we're going to be vascular experts, or we're going to send our patients to vascular experts, we have to make sure that we're looking at all bases when evaluating these patients. The gold standard of treatment of lymphedema is complete decongestive therapy. And again, the whole point of that is to decrease the volume in the limb, compress, ACE wrap, bandage. We have lymphedema therapists in our area, in our practice that we work with. We're phenomenal at what they do. And I urge you to certainly become comfortable with that program in your area. And then the point is, though, that the treatment is lifetime. This is not a one and done thing. This is not a quick in and out. These patients have to take some of the onus of compression, of utilizing a pneumatic compression device, maybe even, that would sequentially pump some of the fluid from the area. So again, very, very important that these patients understand that. And in the next final minutes, I just want to go over a couple of cases of mine that I've evaluated in the clinic. This was a 58-year-old female, bilateral leg swelling, as you can see on the screen. 5 years. We've all had patients that have come through the clinic like this with long-term swelling. She's a college professor. She's noticing it's worsening. She's becoming very, very conscious of it. She doesn't want to wear shorts or skirts. Her feet are getting more and more swollen. She's got some achiness. She's starting to gain weight now because she's becoming, she told me she's becoming depressed. Her BMI's gone up to 40, and that's what her legs look like. A lot of times in the clinic, these patients are being placed on diuretics, especially in our primary care colleagues' offices. And I have to say that it's very important. While diuretics are good at what they do, diuretics are a Band-Aid for patients that have lymphedema. Diuretics may cause increased urination and take some of that fluid out, but let's understand that that fluid will come right back because we're not taking care of the underlying problem. So this patient kept taking diuretics, was up throughout the night urinating, but was not getting any relief. She was seen by an outside venous ablation group or venous specialist group that did multiple ablations, and the veins kept opening back up. So she came to us and said, what are we missing here? And so we thought about the pelvic veins. If the pelvic veins are narrowed, the superficial veins will keep opening back up. So this patient had venous recurrence. So she had a pelvic venous ultrasound performed. However, she was obese, so very difficult to see. But when her legs look like this, and she's got all these symptoms, we have to do better, right? We can't just say that, hey, you know what, let's just keep ablating the superficial vein, because that is not the right thing to do. We have to do better. We have to think outside the box. So we went ahead, we did a venogram on this patient. We injected dye in the legs. We can see here the patient had compression in both her left and right common iliac vein. As the dye is making its way up, you can see some of the lightness there. And we went ahead and stented her legs. She had stent on both the left and right sides. So we walked out feeling really good about ourselves. We felt that she was going to do great. At 6 months, she came back, said, I feel fantastic, but my legs are still swollen. And we were a little bummed about that. But then I thought about it more and more, and I said, well, I'm missing the lymphatic component. I've treated the phlebo side, but what about the lymphatic side? So we went ahead and put her on a complete decongestive therapy program with a pneumatic compression device as well. And ladies and gentlemen, take a look at this. This is at 6 months. This is before, this is after. We've changed this lady's life. She's come back, she's reinvigorated. It really, really goes a long way. This is a patient who had an ulcer. This patient walked around with an ulcer for 6 years. 6 years, was seen by various specialties, wound care. The ulcer would get better, but it would come back. She had a history of a DVT in her left leg about 15 years ago. Came to our practice. We looked into the pelvic compartment to see if there was any narrowing higher up in the iliac veins that could be leading to that translation of pressure down the leg, causing this ulcer to open back up. We went ahead and did a venogram because the pelvic ultrasound was equivocal. Now, what I want to show everybody here is that as you see the dye going up both the left and right iliac veins, where the arrow is, you can see that that area certainly is questionable. There's some narrowing there. It doesn't look the same way as it would look on the right side. And what you also see is you see all these little lines going across the pelvic area. So what's happening is blood is making its way up the left side. It's hitting some resistance here and coming across the left side, so into the right. So there's certainly a question here, right? We did IVUS, intravascular ultrasound, again, which is a three-dimensional view of the vein from the inside. If we're going to treat deep veins, we have to use intravascular ultrasound. It's the right thing to do. Otherwise, we'll miss about 26% of lesions, if not. So what did we see? We saw irregular borders. We saw projections into the vein that looked like chronic scarring. Ladies and gentlemen, this patient had a blood clot 15 years ago. It was adequately treated with blood thinner, okay? Nothing was done wrong. But we have to understand that 48% of patients that have had a blood clot will go on to get chronic scarring in their veins. They will have chronic swelling. So please don't chalk it up to, oh, it was a blood clot years ago, it'll go away. It won't go away. It needs to be evaluated further. This patient wound up getting a stent in the left side. As you can see, no longer do you see any type of collateral branches going anywhere. You see nice blood flow going up. And how did it also do? At 3 months, she said, you know what, it's okay, it still hurts. You know, looks like it's starting to heal there, but we went ahead and accelerated that process by helping the lymphatic side, got her into a complete decongestant therapy program. And at 6 months, ladies and gentlemen, that was the first time in over 6 years she had a closure of that ulcer. So don't feel bad. This is from the Lymphedema Treatment Act. Most physicians in the United States are taught in medical school, 4 years of medical school, 1 hour or less of lymphatic system science. So don't take it too much to heart. I really appreciate, you know, the wonderful attention here. Just in conclusion, again, like Dr. Lokampal said, it's a team-oriented approach. We are very proud at the Center for Vein Restoration to have our vascular specialists as our colleagues here. It's a multidimensional. We have to have realistic expectations for our patients. The patient plan has to be goal-directed. We're not going to treat these, we're not going to fix the problem overnight, and they need to understand that, but it's how we translate the information to them. Please understand that lymphatic systems become overtaxed when venous insufficiency occurs. So in your chronic patients that have leg swelling, C3 and above, please think about lymphedema as well. Timely recognition will help these patients in the long run. And again, I'd like to thank everybody for their wonderful attention. And we are going to take it back to Dr. Lokampal so he can open up the floor.